Hello guys, I am Keshav Sharma and welcome to my new YouTube channel Maniac Medico. Today we will be studying about pharmacology and we will have various other subjects related to MBBS. For now, let's get started with pharmacology, and it is a very interesting subject. So let's begin with what is pharmacology. So pharmacology basically refers to the study about drugs. Yes guys, including the drugs which you guys also thinking about. Yes, they also come under this, but initially we'll be dividing this lecture into two parts, that is kinetics and dynamics. So what is pharmacokinetics? Very interesting. So pharmacokinetics, which means what the body is doing to the drugs. So we can divide this into four phases, which is basically absorption, distribution, metabolism and excretion. So here we will be studying with absorption first. So what is absorption? So whenever a drug is given to a patient, be it orally, parenterally, through intravenous routes, or through rectal or any other route, so the drug first has to enter the systemic circulation. So from the site of administration to the path where it enters the circulation is called absorption. So here it is, absorption, transport of drugs from site of administration to systemic circulation, in simple words. So there are basically various mechanisms through which the drug can be absorbed. So first one is passive diffusion. As we know, diffusion is what? Movement of a substance from one place to another place based upon the concentration gradient. From higher concentration they move to a lower concentration. So first is passive diffusion. So here what happens is, in passive diffusion we don't need ATP, we just need a concentration gradient. So what happens here, it says lipid soluble and non-ionized drugs cross easily. Why? Because our lipid bilayer membrane, it is of lipid, right? So a lipid soluble drug can cross easily, whereas a water soluble drug, it needs certain porins. So when we study the lipid bilayer membrane, so if this is the membrane, so we have certain proteins, carrier proteins over here, which allow the passage of certain drugs. Suppose this is a drug X and this is H2O soluble. What happen? It will come here. It won't be allowed from here. No, because it is not lipid soluble. What will happen? Instead, it will use a porin. That is what is called as an aquaporin, through which these drugs can enter. The second way is facilitated diffusion. So here what happens is, we need certain carrier proteins. So what happens over here is, suppose the classic example, glucose is always transported with sodium, right? So whenever glucose enters the membrane, it needs sodium for its transport. Similarly, we have an example over which is GLUT4, which is present in the adipose tissue and our skeletal muscles. Next we can come to active transport. So in active transport, what is happening is, first of all we need ATP, right? Energy is required, and what happens is, this against the concentration gradient. Like how we studied in diffusion, that was from high to low. Here what happens is, from low to high the transport takes place. So one of the examples over here is P-glycoprotein. These help in the transport, but then again they require the ATP. Next is penocytosis. Penocytosis is what? Cell drinking phenomena. Basically the cell comes and engulfs the certain drugs. So here what happens is vesicular. I will tell about it. So the cell engulfs by the plasma membrane. So what happens is, we have a classic example of VMAT2. So this stands for vesicular monoamino transferase 2. So this comes when we study about adrenergic drugs. So what happens is, this VMAT2, it takes up noradrenaline in the axonal membrane. So noradrenaline is actively taken up by this VMAT2 in the axoplasm. So here are certain ways through which absorption of drugs can happen, and next we'll study which of the routes are the fastest. So what happens is, initially inhalation drugs are the best. This happens through the nose. You give the drug, you basically inhale it, and this goes to the lungs. So the tissues of the lungs, they absorb the drug. This is the fastest route. Next we know, as everybody knows, IV, because in case of emergency the drug is delivered through intravenous so that it can enter the blood directly. So IV. Next is sublingual. So I'll give you an example of a piroxicam. This is a NSAID. D. So this stands for non-steroidal anti-inflammatory drug. So piroxicam, we can use this for the treatment of migraine, and it is given sublingually. That means we place it under the tongue, and the area is highly vascular, so it just goes to the blood very easily because we have many capillaries over there. And also through inhalation, sublingual, intravenous, we are exiting the first pass metabolism. We'll discuss about this later in the video. Just note that first pass metabolism. Then is intramuscular, subcutaneous, oral, and transdermal. Transdermal, we can use it for nicotine. Like people who are addicts to cigarette or tobacco chewing, whatever it is. So we use a nicotine as a transdermal patch. We just apply it on their skin so that the nicotine goes in, but then the adverse carcinogens like carbon monoxide or the soot, anything doesn't enter their body. So this is also basically this method, transdermal patches. It is used for freeing addiction from the people. So this is all about absorption. I hope you guys understood. Now we'll come to distribution. So what is happening in distribution? So here it says once drug enters the blood. So in absorption, what we did, we have entered the blood, the drug has entered the bloodstream. So what happens here, once drug enters bloodstream, its distribution to tissues against, like we saw again through concentration gradient, against the concentration gradient being directed from the plasma. So what happens over here is, from concentration gradient, suppose I had to say this is a membrane. So this is X, this is Y. X has 20 units of drugs and this has 0. So what will happen? Technically it will move from here to here up to when equilibrium is attained. So until I have 10 on this side and I have 10 on this side, the drug will continue to move, right? So again here we have the same rule, lipid soluble drugs are distributed faster, yes. And also there is a criteria that if an area which has higher blood flow, for if I had to give you an example in the GIT, the liver has a good amount of blood flow. So yes, the drug will go to the liver, there's more chance of the drug entering the liver, and also higher rate of distribution for certain drugs. And also yes, when we study about certain drugs, it also depends upon the plasma protein binding ability. Like we have few drugs which bind to the plasma protein, like albumin, which are acidic drugs. Then there are basic drugs, there are various type of drugs which can bind to the plasma protein. So what happens here is, yes, it will bind to the plasma protein, and we know a relation that binding is inversely proportional to distribution. The greater the binding, the lesser will be the distribution, because the drug won't be in its free state, it will be bound to the plasma protein, right? Now see, as I told you, acidic drug binds to albumin, and the basic drugs, they bind to alpha-1 glycoprotein. So this is all about distribution. And yes, if I had to give you some example, like diclofenac, they have the maximum binding to the plasma protein. Like if you are giving a person 100 milligrams of diclofenac, probably in the free state in the plasma there might be just 2% of diclofenac, because 90% of them gets bound to the plasma protein, like albumin or whatever it is. Valproate, again, it is an anti-epileptic drug. This can also bind to the plasma protein, but this is 30%. Next is digoxin. So this is a cardiac glycosidase which binds 25% to the plasma protein. So next is redistribution. So what happens here is, suppose a certain drug which is highly lipid soluble, which can bind to lipid very easily. So what happens over here is, these drugs first go to the site where there is maximum blood flow, be it liver or any such organ like that, which has maximum blood flow. And after some time they get redistributed to the bulky masses, like skeletal muscles and adipose tissue. They are bulky tissues in the body, so they get redistributed there. And also being more lipid soluble, they get bound to those places. So I had to give you an example, thiopentone. So this is a general anesthesia. So whenever you are giving thiopentone, so it is given through inhalation, right? So whenever we are giving thiopentone, so what happens is, the action is seen immediately, yes, because it will go to highly vascularized area wherever there is more of blood flow. But when the patient tries to recover from the anesthesia, it takes certain longer time because thiopentone is bound to the adipose tissues. Next is tissue storage, yes. So tissue storage, what happens over here is, our body has certain organs in our body, they store few amount of drugs, right? So here a few examples, like skeletal and heart muscle, they store digoxin, I told you it's a cardiac stimulant. Hematine, then liver and kidney, they store chloroquine and tetracycline. Chloroquine, you might know it, hydroxychloroquine, which is an anti-malarial drug, and tetracycline is an antibiotic. Thyroid stores iodine, as we all know it, and the brain, they store isoniazid and chloropromazine. Next, let's come to what is metabolism. So metabolism or biotransformation. So this is a bit lengthy topic. So I will explain it to you in details, right? So what happens here is chemical alteration of lipid or non-polar, lipid soluble or non-polar drug. So if a drug is lipid soluble, it cannot be excreted by our body. It has to be changed to a water soluble drug because it has to be excreted through urine, and maximum of our drugs are excreted through urine itself. Or a polar drug or a water soluble drug. Suppose we give a patient a polar drug, but then it has to act on a organ, so it has to be changed to a lipid soluble form so that it can enter, and again it has to be changed back for its excretion. So whatever is happening over here is this chemical alteration. So for this we need an enzyme, and all this activity takes place in our liver. So what happens over here is drug is there, in presence of certain enzyme it gets metabolized. So as I told you, mainly in the liver and other organ sites such as kidney, lungs, brain, intestine, and these all can happen. So as we study about biotransformation, there can be of three types, because whenever we give a drug, either we are giving a very active drug or a prodrug, which is an inactive drug, or a moderately active drug, and it has to be converted based upon its fate. So active form. So if I give an active drug and it has to be converted to an inactive form, like paracetamol, very classical example, or propranolol, it's a beta blocker. It is a non-selective beta blocker. It can act on both beta 1 and beta 2 receptors. So what happens over here is whenever we give these two drugs, these have to be transformed. So these are very active drugs, and paracetamol, if it is not deactivated or inactivated by the liver, it can be very hepatotoxic. So we have to make it into an active or a less active form. Next is from active to a more active form. Like you guys might know about codeine. Codeine is given in cough syrup to reduce painful cough. It was given, it got banned due to people who was abusing it. So what happens is codeine is converted to morphine in the liver. Reason why you guys feel sleepy after taking it. Or digitoxin to digoxin. So digitoxin is an active compound. Digitoxin is an active compound. It is converted to digoxin. Next we can come to inactive form to active form. That is, for Parkinson's is a classic example. We give the drug L-DOPA or levodopa. What happens here is L-DOPA is converted to dopamine, and it is given to the dopaminergic neurons in the brain. So what happens is this is an inactive form, and L-DOPA cannot cross the brain barrier. It has to be transformed. And very interesting part about DOPA is they stimulate the production of dopamine. They don't give dopamine directly. Right. So this was about metabolism, but we have few more phases to discuss. But let's discuss about first pass metabolism, which I spoke previously. So what is first pass metabolism? So what happens is metabolism of a drug from site of absorption up to systemic circulation during its passage. So a drug, right, whenever we give it to a patient, from absorption to the drug entering systemic circulation, there is a certain phase of metabolism which is taking place with the drug. Like I told you guys that if I give a drug sublingually, it is not necessary that it has to undergo first pass metabolism. It can escape it. If I give it intravenously, it's going directly to the bloodstream. But if I'm giving a drug orally, like suppose if I give a patient lacosamide, an anti-epileptic drug, or even maybe valproate, again an anti-epileptic drug. So what happens is this drug goes to the mouth first, then it follows the route of GIT. GIT, if I'm referring, so these drugs get absorbed in the intestine, so I'm referring to the intestine over here. Some drugs do get absorbed in the stomach also, but mainly we are talking about intestine over here. So what happens is there are many capillaries over there in the intestine. So these drugs are absorbed by the capillaries. So it enters the bloodstream. Now what is happening is via the hepatic portal vein, right? Intestine, be it stomach. So what happens is they go to the hepatic portal vein first. And over there the liver metabolizes these drugs into these three forms. That is active to inactive, or active to more active, or inactive to active. So what happens is the net bioavailability of the drug is reduced over here. That is why you guys might have noticed that whenever we are giving a drug orally, so we give very high amount of drug orally, because the net drug which is remaining for activity, like for the therapeutic effect, is very less in oral compared to sublingual or probably intravenous, which is the highest, right? So what is bioavailability? So the amount of drug which is there in the blood for therapeutic action. So whenever I am giving a drug orally, so suppose if I give a X drug 100%, that is, let's take 100 milligrams, at the end of first pass metabolism, only 20% of the drug is left. So we have a various criteria how we can give the drugs to the patients depending on which drug has higher first pass metabolism, or maybe which drugs needs to reach in a higher concentration in the body. Then we can choose the route, be it given intravenous or orally. So, but you always remember that in orally the drug dosage is very high because of high first pass metabolism. Because if I'm giving 100 milligrams, only 20 to 30 milligrams is reaching to the patient, which is not sufficient for the therapeutic action. So that is why hence the drug frequency also increases over here and the dosage also increasing. So here we can learn it with the help of a graph. So what happens over here is, this is the concentration of the drug on the y-axis. On the x-axis there is time. So whenever I am giving a drug orally, initially the concentration is very high, with time it reduces. And when you see orally, it is increasing and decreasing, right? So what does the formula state to us? F is nothing but we represent bioavailability with the letter F. So what happens is 100 into area under the curve orally. So this area, let me mark it for you guys. This area, right? This area under the curve orally into the intravenous dose, whatever is given, upon area under the curve intravenously into oral dose. So this will give us the bioavailability of a drug, right? And metabolism, we have two phases in this, right? There's phase 1 and phase 2. So in phase 1, basically there is non-synthesis of drugs, or it is also called as a functional reaction, whereas the phase 2 is synthetic conjugation. So guys, let's continue about metabolism. So we were in metabolism, right? So now we will discuss in the phases of metabolism what actually happens in each different phase of metabolism. So initially we need to know, as I told you previously, that the enzymes are required. It's like the drug goes to the liver, the enzyme converts it into a metabolite. So we'll study about the enzymes first. So what is the enzyme? So either it is microsomal or non-microsomal. So what is a microsomal enzyme? Which is located on the smooth endoplasmic reticulum in the liver, kidney, lungs, or various other organs. It could be intestine also, where the metabolism of the drug is taking place. So example for this, cytochrome P450. So cytochrome P450 might have heard many times, even in biochemistry, even in your 12th standard biology. So what is cytochrome P450? So this is a microsomal enzyme which is required for detoxification of xenobiotes, or maybe any antibiotic or any drug we are taking. The major detoxification takes place because of cytochrome P450. Here is why people keep telling you that liver performs your detoxification in specific smooth endoplasmic reticulum. Another example is monooxygenase, glucuryl transferase, and various other enzymes. So what happens is these enzymes catalyze either oxidation or reduction reactions or hydrolysis. We will discuss them in details later. Next is non-microsomal enzymes. So they are present in the cytoplasm and mitochondria of hepatocytes or the liver cells. So example over here is esterase, amidase, or flavoprotein oxidase, various other enzymes. So let's study about the phases of metabolism. So what does metabolism actually do to the, we know the enzyme is converting it into a metabolite. So what is happening here? So first one is non-synthetic, right, or functional metabolism stage or phase 1. So here what is happening is we are making the drug functional so that it can give us a therapeutic action. So what happens over here? Metabolism may be active, as I told you, it can be active form to an inactive form, or inactive to an active, or active to a less active form. So it can be either active, like if I give L-Dopa, it is converting to dopamine, or inactivation of certain drug like paracetamol, it undergoes oxidation and hence we have to deactivate the drug by adding or unmasking. So any drug is a chemical, right? So they have functional groups. So either we are adding the functional group or we are unmasking it. But if it is covered by certain bonds over here, if a metabolic enzyme comes here, it will unmask this phase so that a metabolite can act, and a functional group can attach to this. So what are the functional groups? Like OH group, alcoholic group, amino group, or thio group, sulfur. So oxidation, as we all know, what is oxidation? It is either addition of oxygen or addition of a negative charge, removal of a positive charge, or removal of H+, which is H+ ions, hydrogen ions. So example for these drugs are again barbiturates and paracetamol. So as I told you, paracetamol undergoes oxidation. Next is reduction. So it is vice versa of oxidation. What happens here is we're adding negative charge here, so we'll add positive charge over here. So addition of H plus, or positive charge, or removal of negative charge, which is oxygen. So the drug which undergoes reduction is warfarin. So what is warfarin again? Very important drugs for heart patients. So any person who's gone under valve replacement surgery or any surgery like CABG or something, so they are desired to consume warfarin because this helps to thin the blood. Right, it doesn't make the blood more viscous. So when we check about the PTINR, that is prothrombin international normalizing ratio, so what happens is we have to maintain their blood to a certain level of PTINR. Like normally we'll have at least 1, 1.5, 1.15, but for them it has to be at a different level. Just that the blood doesn't stick to the valves, mechanical valves, or whatever has been attached to them. So we use warfarin. It is a aspirin derivative. So I'll tell you one thing. Wherever we see in, so just warfarin, ecospirin, so these are all aspirin drugs, right? And we know that aspirin is responsible for thinning blood. Next is hydrolysis. So what is hydrolysis? It is simple, breaking of bonds by adding of water. So what are the examples of it? Like cholinesterase and procaine. Procaine is an example from cocaine. It is a cocaine derivative, yes, and the name of the drug hence procaine. So what happens in phase 1 overall is we are just converting the drug so that it can give us the desired therapeutic effect. Now let's come to, once the drug has been activated, it cannot stay active for entire life, right? It has to be eliminated, it has to be deactivated. Hence, what we will do in this phase over here is we will deactivate the drug. So what happens over here is synthetic conjugation, phase 2, or inactive metabolism. So here what happens is conjugation of drugs or phase 1 metabolites, right? Either a drug directly or a phase 1 metabolite, what I have received from here, with an endogenous substrate. So whatever substrate is present with me inside, we will use it over here. So we can have glucuronidase conjugation or acetylation. So what happens over here, we use conjugation with glucuronic acid and UGT enzyme, right? It is uridine 5-diphospho-glucuronide transferase enzyme. So that is what UGT stands for. And example of such drugs again is aspirin and morphine. Next is acetylation. Compounds with acetyl or amino group are conjugated with acetyl coenzyme. We know about this again in biochemistry. So example of such is sulfonamides. These are antibiotics basically again. And we have few more examples such as methylation for adrenaline. Sulfate is chloromfenicol. Again this is an antibiotic. Glycine with salicylates and glutathione, again paracetamol is an example over there. Next is, we are done with metabolism, but what are the factors affecting metabolism, right? So first is enzyme induction. So it is basically how the enzyme acts, the ability of the enzyme certainly to metabolize a drug to a certain product. So if we have a shortage of enzyme or something, then again this phase won't be functional. So what happens next is enzyme inhibition, that is decreased drug metabolism of enzyme. In case of, suppose we have a condition of a patient and the drug we are giving to him is not functional. So instead of thinking why the drug is not working, we perform certain tests on the patient, right? So suppose our patient has some liver disease like cirrhosis or hepatitis, or maybe the drug's bioavailability is very much high, like in the plasma the blood is present in a very high amount, then again these enzymes cannot convert it to an inactive form. Next is decreased blood flow to the area. If there is again less blood flow, then there is less inhibition of the drug, and also there is competitive inhibition. Suppose two drugs, they can compete with each other for the active site, and the other drug which I am giving and the desired drug of therapeutic effect is not showing action but the other drug. And the next one can be age. Again, yes, this is a very important thing. Infants and old people. In infants, what happens is the liver is not developed so much, so the microsomal enzymes are not present yet, right? They are not present yet, hence they can show various drug dependence effect, which we will study in pharmacodynamics. Same with old people, yes. In younger people, yes, it is fast. Next is sex, either females or males. So in female, the metabolism is slow, right? Whereas in male, it is fast, because in general we know that the metabolic rate of a male is faster when compared to female, right? Next is pregnancy, can be a case which has many other complications, many other things to study, and there can be hormonal imbalance. Hormonal imbalance, specifically which one I am referring to, that can be thyroid hormone, which is responsible for metabolism. So these were all the phases of metabolism and how metabolism takes place. And we will study about excretion, how the drug is excreted. So what have we studied till now? We have studied about absorption, distribution, metabolism or biotransformation. Now we will be studying about excretion. So how is the drug excreted? Once all this has happened, the drug has showed its desired therapeutic effect, the drug cannot stay there forever. It has to be removed or else it will cause toxicity, right? So how the drug is removed? We have converted to an inactive form now. We had an active form, it is converted to an inactive form, but this has to be excreted. So as I told you, the drug has to be excreted in water soluble form, right? So here we'll convert the drug into water soluble form, the liver will do it, then it will go to the kidney, and how the excretion is taking place, we will study about it in detail. So guys, we have completed absorption, distribution, redistribution, and metabolism also. Now we will focus upon excretion, because the drug has entered the body, it has given the desired therapeutic effect to the patient. Now it has to be eliminated, right? It will cause toxicity. So what is excretion? Process where the drug or its metabolites are irreversibly transferred from internal to external environment through renal or non-renal routes. So basically we have various ways of excretion, which can be either renal through the kidneys, mostly it is renal, few drugs through biliary excretion, few through the surface of skin, few through the surface of lungs, which is through inhalation and expiration, and the other ones can be mammary also. So we will study about renal and biliary excretion in detail, and the biliary excretion has a catch in it, which is a bit interesting. So this scheme can show you basically like kidney, liver, lungs, however the drug is given, it goes to the liver, goes to the blood, first pass metabolism takes place. If it is to parenteral, it will go directly. If it's to the gut, oral, rectal, it will go again to the portal vein first, then from the portal vein it goes to the liver, then to the blood. So that's how it works. This is a scheme which shows everything. So what happens here is, we have a few important things to note. Water soluble or polar drugs can be eliminated through the kidneys very easily. Lipid soluble or non-polar is eliminated through bile, because bile is what? It is made up of cholesterol, right? Bilirubin, biliverdin, or the bile salt, and has cholesterol in it. Inhaled, like example, if I could give you your inhalers, salbutamol, which can be an inhaler, which is also again a selective beta blocker. It can be excreted through the lungs, or if I could give you another example, ethanol can also be excreted through the lungs. So let's speak about renal excretion now. So in renal excretion we have three phases, just like how the urine is formed: glomerular filtration, tubular reabsorption, and tubular secretion. So what happens over here is approximately 120 to 180 ml of blood is filtered per minute. So because of the large pores in the Bowman's capsule, what happens is the lipid soluble drugs are filtered out. Okay. The next phase is tubular reabsorption. So the lipid soluble and non-polar drugs, they diffuse back because 99% of the primary urine which is formed is reabsorbed, right? Not everything is gone out. So they filter out and then they are reabsorbed because they are not soluble in water. Next is your tubular secretion. So what happens is this carries at the level of proximal convoluting tubule, we all know, and this is an active process. So what happens over here is, there are few transporters over here like OAT, organic anion transporter protein, which transports drugs such as penicillin and salicylic. So this could be aspirin, can be an example of it. And for basic drugs, again for organic cation transporter, example morphine. So this is how the renal excretion works. Simple way, the drug is liquid soluble, water soluble, it just excretes out. If it is lipid soluble, it has to go through various processes. Again, it will go to the biliary excretion. So what happens over here is, we have a formula also for renal excretion, how we can calculate it out. Net renal excretion, I will tell it to you. I have written all the formulas over here, from which you can get some numericals. I will discuss later. So what happens next is the biliary excretion. So what happens over here is, we also have a transporter over here, again see organic anion transporting protein polypeptide. So over here it is PGP and MRP, right? They are the two transporting proteins over here. So what happens is, all the lipid soluble drugs can be excreted through the biliary route. So here there is a very interesting thing which happens in our body, which is called as an enterohepatic circulation or enterohepatic cycle. So what happens is, the drug whichever we have consumed reaches to the liver. The liver passes on the drug to the bile, because it has to be excreted now. So the drug goes to the bile, Where is the bile present technically? Yes, in the gallbladder. Now what happens? The bile is poured out. So it goes to the GIT. GIT particularly interested in the large intestine. So before it enters the feces, what happens is when the when the bile is poured into this thing, into the large intestine, what happens is the xenobiotes or the bacteria which are present over here in the intestine, which you also refer to as the good bacteria for our gut. So what they do is, basically in the appendix they cause fermentation, right? So they alter the drug. So whatever the drug which was inactive, it is converted to an active form. Now what we have studied is the active drug always enters the liver, right, for metabolism. So again this drug goes to the liver, and what is happening is it is again metabolized, and the cycle continues until the drug is finally eliminated through another way, or we will have to take it out. So what are the advantages of this? So the advantages, the duration of drug action is prolonged. But again, as I told you, if the drug is present in our body for a long time, it causes toxicity. So what is the best thing? We use activated charcoal powder. So the activated charcoal will absorb, it not absorption, it is adsorption on the surface, and then it can be removed through again feces. And we have again various other types of excretion such as pulmonary. So what happens in nitrous oxide? This is an anesthesia, right? It is given along with the anesthesia, sorry. When general anesthesia is given, it is given along with the anesthesia. So this is less soluble in blood, easily excreted. Even ethanol, for an example, they go through simple diffusion. Next is in saliva. All the lipid soluble drugs such as caffeine and phenytoin. Again, yes. What happens here, if you swallow the saliva again the active drug enters, the inactive drugs will go inside your body, it will go to the liver again, the cycle continues. So example is caffeine and phenytoin. Next is through mammary glands. Again lipid soluble drugs, yes. Morphine, that is why women shouldn't get high during their pregnancy or when they are lactating. Skin, benzoic acid, salicylic acid, and certain heavy metals. So if I bring your focus over here, when we talk about elimination, we talk about plasma half-life. So in how much time the given concentration of drug is converting to half of its original volume. Suppose if I take aspirin, if I have given a person 100 milligrams of aspirin, in next 4 hours it will become 50. In the next 4 hours it will become 25. So for every 4 hours it will decrease its concentration in half, right? So that is what is called as a plasma half-life. So for aspirin it is 4 hours, penicillin 30 minutes, digitoxin it is 7 days, digoxin, which is the active form, it is 40 hours. So we study a bit about kinetics over here. So drug is eliminated either through zero order kinetics or first order kinetics. So in zero order kinetics, what happens is clearance is inversely proportional to the concentration in plasma, right? Whereas in the first order kinetics, it is directly proportional to the concentration in plasma. So if the dose is constant, the clearance remains constant in the zero order reaction. Now the interesting thing is, if the order changes, for certain drugs they cannot be excreted from first order kinetics, they are excreted through a zero order kinetics. So what happens over here, if the order changes from first order to a zero order kinetics, then the order is called non-linear elimination. So here we cannot give statements such as if the dose is constant, the elimination will be constant or clearance will be constant. So here I have a few conversions over here. So we know for T half of the first order reaction is 0.693 by K. Okay, for the zero order kinetics T half, it's also called as Michelin-Menen constant. You might know about it, biochemistry might have heard about it. So ln2 by K, which is 0.693 by K. So I know K is what? Clearance upon volume. T half is what? 0.693 into V upon clearance. So this is an important formula for you guys. You can get many numericals on this. Next is net renal excretion, as I spoke about it in the renal excretion. So what is the net renal excretion? How much of drug is going out to the kidney? So we add up glomerular filtration plus tubular secretion, right? Filtration plus secretion, because these both are adding up, and this is the final place where the urine is eliminated. So we subtract it from the tubular reabsorption. So we have net renal excretion. Next we have another formula for clearance. It is the rate of elimination upon concentration in plasma. So I hope you guys have understood pharmacokinetics. If you have any doubts, you can ask me in the comment section. You can take the PDF for this entire notes from me also. I will add up about those details in the description. And if you liked the video and if you're looking forward for more such videos, please do like, share and subscribe. We will also be discussing subjects like morphology, pathophysiology, biochemistry, anatomy and various other subjects. So please Do like, share and subscribe, and thank you for watching.